in terms of perinatal mobility and mortality. So let's start with the topic, which is the antenatal diagnosis, surveillance, and management of intrauterine growth restriction. Previously, this term was used like intrauterine growth retardation. Now it has been recently replaced by the term intrauterine growth restriction. IUGR or IUFGR is the fetus who is unable to grow in its genetically determined potential size to a degree that affect the health of the fetus. It means that the 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 potential genetically potential which are supposed to be for the growth of the fetus, if they are not appropriately reached, then the baby will be in the growth retarded condition, which can help the affect the health of the fetus in terms of increased morbidity or increased perinatal death. A small for gestational age. We have to see what are different levels of weights of the babies, and when we plot on these weights on customized charts, there are three zones of the growth of the fetuses. The one zone is the appropriate for gestational age, which lies between 90th and 10th centile of the gestational age. These are the babies who are growing well. They don't have any problem. They are low risk babies, and they have good perinatal outcome. Then the extreme of the growth is the large for gestational age. If the babies are going on the 90th centiles of the given at a given gestational age, then these babies are large for gestational age. These babies are also prone to have worst perinatal outcome. On the other extreme, there is the small for gestational age, which are the babies which are growing at the 10th centile for a given gestational age. These are the babies who are growth restricted or small for gestational age, and these are prone to have different problems in terms of bad perinatal outcome. So, small gestational age is defined as the estimated fetal weight or abdominal circumference less than 10 centile, and severe SGA is as estimated fetal weight or abdominal circumference less than third centile for gestational age. So we can differentiate between as severely SGA and normal SGA babies. Now, there are numerous factors in the mother, in the fetus, placenta, which can affect the growth of the baby. The potential factors which are present in the fetal are the mostly fetal anomalies or the fetal abnormal chromosomes that can lead to defective fetal growth. And these are the babies who they show their growth in the initial half of the pregnancy, that is the before 24 weeks, and these are mostly symmetrical IUGR babies. On the other hand, the maternal factors are numerous, and in these factors they are chronically ill problems which can result placental which can affect the vascular structure of the body, which resulting into defective placental supply, and then can affect the babies. These are the mothers and the babies who show their growth restriction after in the second half of the pregnancy, mostly in the last trimester, third trimester of pregnancy, and these babies usually end up with asymmetrical IUGR. There are also placental factors which can affect the placental blood supply to the fetus and can affect the growth of the baby. The maternal factors mostly are the chronic illnesses like diabetes, hypertension, renal disease, antibody lipid syndrome, autoimmune diseases. All these chronic illnesses affect the vascular structure of the mother that in turn result in the decreased blood supply to the placenta and then can affect the growth of the growing fetus. Now, normal growth, usually growth is the number of the cells as well as the increase in the size of the cell. The cellular hyperplasia usually starts from the very beginning of the pregnancy and lasts up to 6 weeks. Then in the latter half of the pregnancy, there is hyperplasia of the cells as well as hypertrophy of the cells, which lasts for 16 to 32 weeks of pregnancy. And after 32 weeks, the main problem is the hypertrophy. I mean, if there is growth is restricted, there will be decreased hypertrophy of the cellular organs. Most of the fetal weight gain occur usually beyond 24th week of pregnancy, that is two-thirds weight gain of the fetus occur after 24 weeks of pregnancy. The pathophysiology mostly there's a decreased potential in the growth of the fetus in terms of decreased number of the cells or in terms of decreased growth of the cells. So mostly the second half of the growth, which is due to the decreased blood supply to the placenta, is usually results into asymmetrical growth retardation that occurs when there is decreased blood supply to the placenta. Resistance in the placenta increases, resulting into decreased nutrition to the fetus as well as decreased oxygenation of the fetal blood. This results into hypoxia. This results into the hypoxia of the uh, fetus, hypoxemia, acidosis, and then all the consequences of decreased oxygen supply to the fetus. In this condition, there is brain sparing effect, like brain, the vascular organs, the most active organs like brain, adrenals, and the heart need more blood supply. So there is shunting of the blood from the peripheral organs to the central organs. That's why there is a brain sparing effect. Brain continued to grow, and this results into decreased blood supply to the organs like kidneys, like muscles, and other system. This results into decreased movements of the fetus in terms of reducing movements of the limbs, and also decreased blood supply to the renal results into decreased urinary output of the fetus, which appears in terms of oligohydramnia. So most of the cases where we see there is placental insufficiency, there is decreased fetal movements of the fetus as well as decreased amount of the liquor, and that is due to reshunting of the blood towards the central organs which are more active. Now, there are three types of small for gestational age. The normal small, which are usually known as constitutionally small babies. These accounts for 70 to 80% of the babies. Then there is another group which is non-placenta mediated growth restriction. It means the placenta is not taking part in the pathology. It's the intrinsic factor in the fetus which can affect the growth potentials, and these are mostly chromosomal abnormalities, congenital abnormalities, inborn error of metabolism, and fetal infections. And this accounts for 5 to 10% of fetuses, and that most of the time is symmetrical growth restriction. Placenta mediated restriction accounts for 10 to 15%, and in this condition there is decreased blood supply to the placental bed. Resistance in the placental bed increases. This results into decreased availability of nutrition and oxygen to the fetus, and resulting into asymmetrical growth retardation. Asymmetrical growth retardation means when the head is growing well but the abdomen is not growing well, and then the ratio abdominal head circumference to abdominal ratio is increased. So there is asymmetry in the growth of the fetus. The constitutionally small gestational age fetuses counts for, as already said, 70 to 80%. In these fetuses, the fetuses are normal. They don't have any extra structural or chromosomal abnormalities. Their growth velocities are absolutely normal. There is no hypoxemia in terms of resulting decreased liquor or defective umbilical artery Doppler waveform. It means that the babies are growing well. There is no danger to these babies, and that's why these babies don't need any regular antenatal surveillance or intervention. The second group of the fetuses are symmetrical retarded fetuses. Symmetrical retarded fetuses are those where there is the defect in the cellular phase of the growth. Because it means that the cellular hyperplasia is affected, and the problem is intrinsic to the fetus, resulting into the decreased growth potential of the fetus, and thus that pathological results are usually due to structural abnormalities or the infection like cytomegalic virus, like toxoplasmosis, malaria, syphilis, etc. In these babies, the pregnancy outcome is usually worse. Asymmetrical IUGR babies in amongst the all growth restricted babies, mostly 80% are asymmetrical, and these babies are affected in the second half of the pregnancy, and usually there is the defect in the hypertrophy of the cell. Total number of the cells remain normal, but the size becomes smaller. Pathological process is usually extrinsic to the fetuses, like the processes or the pathologies are in the mother, not in the fetus cell, and these pathological processes result into the reducing uteroplacenta flow, or by restricting oxygen and nutrition transfer, or reducing placental size. And that's occur. There is shunting of the blood, peripheral shunting of the blood occurs, so that there is increased circulation to the heart and the brain. Now, these are the differentiating points between symmetrical and asymmetrical growth restriction. In symmetrical, the baby is all the parameters are uniformly small. I mean, all the biometry on ultrasound, like femur length, abdominal circumference, head circumference, all are growing on the same rate equally. And ponderal axis, that is the birth weight divided by crown heel length, is normal. In these babies, the head circumference and abdominal circumference ratio and femur length and abdominal circumference ratio is usually normal, so they are symmetrical. I mean, head is growing on the same velocity as abdominal circumference. So though if we take the ratio is usually normal. The etiology is usually genetically determined diseases in the fetuses. The total cell number are decreased, but the cell size remains normal. And in these babies, the prognosis is usually very poor. On the other hand, asymmetrical IUGR, the head is larger than the abdomen. It means the head circumference is larger than the abdomen due to brain sparing effect. There, the ponderal index is low. There is elevated ratio of abdominal head circumference and abdominal circumference. There is chronic placental insufficiency. The number of the cells are normal, but the size of the cells are decreased. And in these babies, the prognosis is usually good as compared to symmetrical IUGR, because in these babies, there are potentially intrinsic factor which can affect the bad outcome of the fetus. Now, how we should diagnose the IUGR? It's a very difficult question, because most of the time we just take one reading of ultrasound and say the baby is not growing well, or baby is, IUGR. But we have to go into depth in the history, examination, and investigation, and then we should decide whether this baby is ghost restricted or not, because we have to manage this baby in terms of delivering in time. Now, in the history, on the first visit, it's very important to take the obstetrical and medical history of the women. There are numerous risk factors which can predict bad outcome of the fetus in terms of growth restriction. There are minor risk factors, there are major risk factors. Minor risk factors: age more than 35, BMI less than 20 or more than 26 to 31, smokers, the cigarette smoking 1 to 10 per day, previous history of preeclampsia, previous pregnancy interval less than 6 months or more than 60 months. So these are minor risk factors. The major risk factors are those where the odd ratio is more than 2. These are the factors which are very important in identification, and even single factor can point out what bad pregnancy outcome. Age more than 40, previous history of small for gestational, previous history of intrauterine death, diabetes, chronic hypertension, autoimmune disease, antiphospholipid antibody syndrome. These are all major factors which can contribute to predict bad pregnancy outcome. Now, in examination, as in routine, we do examine the patient. Besides all the general physical examination, obstetrical examination, important thing in terms of growth restriction identification or prediction, symphysial fundal height is very important. It has got numerous studies and randomized controlled trials as well as systematic reviews have shown that serial measurement of symphysial fundal height is recommended at each antenatal appointment from 24 weeks of pregnancy, as this improves prediction of an SGA neonate. So it should be plotted on the customized chart. On each visit, we should examine the patient and do the measurement of the symphysial height. This is the initial screening test to identify the uh, uh, growth restricted. It has been shown in the evidence that abdominal palpation has limited accuracy for prediction of an SGA unit and thus should not be routinely performed in the context. I mean, we cannot rely on just doing palpation to screen out the patient who will be having later on SGA. This shows the customized chart which is for the symphysial fundal height. Now the central line shows the appropriate growth, but the lower line shows the 10th centile of the growth. So if on serial examination, we should plot our findings on such type of charts, and we can anticipate growth restriction in time so that fetus can be further monitored by doing further investigations. So if there is a single reading of the symphysial fundal height on 10th centile, or there is static or slow growth, we should refer these babies for further evaluation in terms of fetal biometry and umbilical artery Doppler ultrasound. Now, what investigation should be done for identification of or anticipation or prediction of intrauterine growth restriction? Ultrasound has been proved to be a very important tool in the diagnosis, in the surveillance, and the management of these babies. Ultrasound is a single important investigation which can help in the monitoring of these fetuses as well as management of these fetuses. By ultrasound, we do fetal biometry and Doppler studies. Using ultrasound, these are the two main observation which we do by doing ultrasound, and that should be done by expert person. The principles, what should be the principles of identification of growth restriction? It's very important that we should have dating scan of all the fetuses or mothers. Dating scan, because when we don't know the period of the gestation, how can we predict that the growth baby is not growing according to the accordingly? Dating scan in the first trimester is very important. If the patient comes to us, it should in the first trimester it should be done. The discrepancy in the first trimester ultrasound 1 to 3 days plus minus 1 to 3 days, while in this second half, that is the second trimester, it's 1 week, and in the last trimester there is discrepancy of plus minus 2 to 3 weeks. So if the patient comes to at 35 weeks, it could be a 38 weeks or it could be a 32 weeks. So dating scan is very important. Second thing is the serial measurement of the serial measurement of fetal biometry and then plotted on the customized chart, not the population based, the customized chart, so that we can see whether the baby is growing well on the average weight, or is it going higher towards the 90th centile, or the baby is going lower toward the growth restriction zone. And then we can do other investigation. The fetal biometry. By ultrasound, we do fetal biometry, estimating of the fetal weight, and estimation of baby proportionality. This shows that this crown drum length is very accurate in determining the period of gestation. So first dating scan in the first trimester is very important in all the pregnant patients. The fetal biometry include the abdominal circumference, the biparietal diameter, head circumference, femur length, or sometimes, if needed, fetal liver. Then by these biometric measurement, we can calculate the estimated fetal weight. In each ultrasound machine, there are different formulas which are already feeded in the ultrasound, and then these, if we take these readings, automatically the recalculation of fetal estimated weight on ultrasound. Measurement of the body proportionality is the head circumference to abdominal circumference, female length to abdominal circumference, and female length to head circumference. The weight of the baby at any gestation can also be estimated by great accuracy by using polynomial equation containing multiple measurements. Equations are fed in the ultrasound machine. We have to take measurement, and the one of the most important measurement is the abdominal circumference. So abdominal circumference is must in all the equations, but other the other measurement can vary, like BPD, female head or head circumference. So abdominal circumference is right because growth of the fetus is mentioned in terms of estimated fetal weight and abdominal circumference, because abdominal circumference increases or decreases showing the nutrition of the fetus. When the liver size increases, the abdominal circumference increases and shows the adequate nutrition of the fetus. When there is the fetus is deprived of the nutrients in terms of decreased placental blood flow, the abdominal circumference decreases. That show the baby is not growing well. These are the ultrasound pictures which showing the exact size of taking the BPD, the abdominal circumference, and female length on ultrasound. Fetal abdominal circumference or estimated fetal weight, that is tensile can be used to diagnose as SGA fetus. So these are the customized chart where we have to plot all these biometric measurement on these chart, and then we can anticipate the defective or slow growth of the fetus. This shows the abdominal circumference, head circumference, female length, and then proportionality of the different readings. That is the head abdominal circumference ratio. You can see here that the ratio usually near term is 1.1 or near 1. But if the ratio is increased, it means if the head is growing faster or more than the abdominal circumference, the ratio increases. And this shows asymmetrical. We can also predict asymmetrical IUGR by just looking at this chart. Now, other ultrasound, what are the other ultrasound features? On ultrasound, there are other features which can add in the information regarding growth restriction. These are the decreased body fat, decreased liver size, increased echogenicity of small bowel, and increased echogenicity of placenta. Increased echogenicity of small bowel is independent, single independent factor which predicts, it's a very have good predictive value in terms of identification of growth restriction. So if we see increased echogenicity in the bowel in the first or second trimester, then these fetuses should be followed regularly by doing serial ultrasounds and umbilical artery Doppler studies. Doppler studies, the first portion was the regarding the biometry using ultrasound determining the biometry of the fetus. The second part has got the Doppler studies. Doppler studies we do usually for uteroplacental flow, that is on the maternal blood vessel and the important artery, the uterine artery Doppler study. In the fetal-placental blood flow, we do the umbilical artery blood flow study, and the umbilical artery blood flow study is the very important and the primary surveillance tool for the identification of IUGR, growth restricted babies, and then hypoxemia and acidemia in the fetuses. Then the ultrasound, the Doppler studies are also done on the fetal vessels, and the most important fetal vessel, the middle cerebral artery. Doppler will discuss in a little bit detail in next slides. These studies are performed for different purposes. They are used for screening of failed trophoblastic invasion, screening for fetal hypoxia, and distinguishing between different types of small for gestational age. Different Dopplers are used for Doppler studies. They are color Doppler, pulse Doppler, continuous Doppler, power Doppler. And what we do on Doppler studies, we usually see the blood flow velocities. That is, blood flow during systole is increased, and during diastole it should also be remain with a normal limit to supply adequate nutrition on oxygen during diastole of the cardiac cycle. So S stands for end systolic flow velocity. That is the, and it's not end systolic, it's systolic flow velocities. That is the maximum velocity during systole. And D stands for end diastolic flow. ST ratio is the ratio of the systolic and diastolic. If the ST ratio is increased, it means that the systole, during systole, the blood supply is normal, but during diastole, it is decreased. So this shows increased ST ratio shows increased resistance in the vasculature of placenta that result into decreased blood supply during diastole phase of the cycle. PI is the pulsatility index, which is calculated by systolic minus diastolic divided by mean of the velocities, and the resistance RI is the resistance index, is the systolic minus diastolic divided by systolic flow velocities. So these indices as well as these ratios are used in different occasion to identify the babies who are at risk of hypoxia, acidemia, and bad pregnancy outcome. Can we predict growth restriction? Yes. There are numerous studies, systematic reviews, randomized control trials that have shown that the uterine artery Doppler ha, has moderate predictive value for identification of these babies. So if the woman has three or more minor risk factor or one major risk factor, these women should be referred for Doppler artery, uterine artery Doppler at 20 to 24 weeks of pregnancy. So even after, in the first visit, if we take the history detail and we find that there are three or more risk factor or single major factor, these women should be referred for the uterine artery Doppler. It's not necessary that all other low risk patients should have Doppler studies. And these Doppler, uterine artery Doppler is also effective in prediction of the women who are at risk of developing preeclampsia. Then another marker, maternal marker, is the pregnancy associated plasma protein A. If the level in the first trimester is decreased, then this also we consider a bad associated bad pregnancy outcome, and these women are also followed up by doing regular ultrasound. This shows that the uterine artery on the left side, so normal artery showing systole and diastole blood flow during systole and diastole. On the other side, the abnormal uterine artery. This shows the notching, early notching during diastole, as well as reduced blood flow during diastole. So if on ultrasound and on uterine artery, there is the pulsatility index is more uh, or there is notching, then these women should be referred for further follow-up, and these women will be needing serial measurement of the growth as well as umbilical artery Doppler from 26 to 28 weeks onward. Now, what happens in normal fetus? Normal fetus, the umbilical artery resistance is usually in the last trimester, it is reduced. Initially, there is trophoblastic invasion, then results into low resistant vessel formation, and it remains throughout pregnancy. In last trimester, it also the reduced resistance is reduced. That's why increased blood supply to the placenta occurs, and the baby growth is normal. And on the other hand, in middle cerebral artery, resistance is increased. There is decrease and diastolic flow in the middle cerebral artery. This happens in normal pregnancy, but in growth retarded, growth restricted fetuses, there's a reversal of this phenomena. In the umbilical artery, in the umbilical artery Doppler, the resistance is increased. That's why the and diastolic flow is reduced. Either it become absent or it become reverse. While on other hand, the middle artery, the resistance is decreased because there is shunting of the blood. The resistance in the cerebral vascular decreases. There is increased blood supply to the brain to grow. So when we see the middle artery Doppler, there will be increased diastolic flow, and it is the better indicator for fetal outcome in IUGR when compared with umbilical artery in terms of sensitivity and predictive value. This shows the umbilical artery waveform on the upper part. You can see that's the there is the normal flow. There is systole flow during the systole. There is normal flow during the diastole. But in the middle part, you can see that the blood flow during systole is okay, but during diastole there is absent blood flow. This is called absent blood flow. And then last picture shows there is reversal of the blood flow. This is the very bad sign where show that the ST ratio is negative. In the upper half, the ST ratio is more than 3, and the lower half, the lower part, the ST ratio will be negative. That is the ominous sign that may precede fetal demise. This picture shows the like this cerebral artery waveform. Normally what happens that I have told that in normal fetuses the systole is the normal, but diastole there is no blood flow. There is resistance in the brain vessels. So we see that the ratio is mostly increased in normal, but in growth restricted there is brain sparing effect whereby the fetal vessels are there is decrease in the vascular resistance to the fetal brain vessels to increase the flow to the brain, thus diverting blood to the important organ in state of oral hypoxia. So we can see that there is also flow in the diastole. Systolic flow is there. There is also diastolic flow. So what happens when we can predict, we can confirm, we can diagnose asymmetrical fetal growth restriction by doing both the umbilical artery Doppler as well as the cerebral artery Doppler. That, and when we take the ratio of the resistance index in the middle cerebral artery and the ratio of the resistance index in the umbilical artery, it is usually decreased. Normally the ratio is more than 1. If it is decreased, it's less than 1, it means that there is asymmetrical IUGR because the brain is getting more blood, there is resistance is less, and resisting index is increased. While in the umbilical artery, the blood flow is decreased, there is resistance to the blood flow, placental insufficiency occur, and resistance index decrease. That's why this ratio is normal is 1, it is decreased in asymmetrical IUGR. What's the role of ductus venosus Doppler? In normal fetus, flow in the ductus venosus is forward, moving towards the heart during entire cycle. I mean that ductus venosus, throughout the cycle, the blood is flowing towards the heart. But when there is circulatory compensation, decompensation, or the circulatory compensation fades, the ductus venosus will show absent or reversal blood flow during atrial contraction. And if this occurs, the perinatal mortality being at least 60 to 100%. It's a very worst bad sign. This shows the waveform of the ductus venosus, which is in the pathological form. There is reversal of the blood flow in the Doppler of the ductus venosus, and this is very dangerous sign for the fetus. It shows severe hypoxia, severe acidemia of the fetus. So how should we manage these um, babies, right? Management starts with the identification of the problem. When we identify these babies earlier, we can manage properly and we can deliver the baby at time. The main problem is to prevent severe hypoxemia to the fetus that can cause severe acidosis and that can result into worst perinatal outcome. So we have to balance the prematurity against the risk of keeping the baby in the intrauterine environment. And the main aim is to deliver the baby safely by safe method at appropriate time. In high risk pregnancy, if the we see that the woman is at high risk by taking history, that means it's there are risk factors in the mother, then we do the Doppler at I have already said uterine artery Doppler at 20 to 24 weeks. And if the Doppler artery is abnormal, showing notch, we should follow these women regularly at least 3 weeks interval by doing biometry and umbilical artery. If this or if us if a superficial fundal height growth restriction is identified, then every three weeks growth measurement and umbilical artery Doppler is advised. Mean if the woman is having abnormal umbilical Doppler at 20 to 24 weeks, or there is there's this superficial fundal height shows growth restriction, these two groups of the women should be followed regularly at the interval of 3 weeks by doing fetal biometry and umbilical artery Doppler. Um, if the IUGR is detected before 24 weeks, the pregnancy outcome is worst, because these are the babies who have got potentially defective growth potentials in terms of having congenital abnormalities or chromosomal or metabolic abnormalities or intrauterine infection. These babies are usually mostly growth retarded, asymmetrically growth retarded, and investigations can be done on these women by like identification of cytomegalic virus or toxoplasmosis, etc. But the prognosis is very poor in these type of fetuses. From 24 to 35 weeks of pregnancy, if the delivery is not indicated and the umbilical Doppler indices are abnormal, repeat surveillance twice weekly in fetuses with end diastolic velocities present and daily in the fetuses with absent or reversed end diastolic velocities. Means if we want to keep the baby, we want don't deliver the baby, we should follow this baby by doing twice weekly Doppler studies in the women where there is absent diastolic flow. If there is reverse diastolic flow, then these we should follow daily by doing Doppler artery studies. Ductus venosus should be used for surveillance of the preterm. Ductus venosus is usually used for management and surveillance and timing of delivery of the preterm SGA fetuses with abnormal umbilical artery. So if there is abnormal umbilical artery Doppler, we should also do ductus venosus, because before 34 weeks, before 32 weeks, middle cerebral artery has not effective role in identification of fetal acidemia, but the ductus venosus is effective by identifying these fetuses. So if the umbilical artery Doppler is abnormal in the preterm fetuses, then this is also followed by, and they also be followed by doing ductus venosus Doppler. Delivery is indicated in preterm SGA fetus provided the fetus is considered viable and after completion of steroids. So if we if there are certain conditions where we have to deliver the baby, then the mother should be given single course of steroids. What are those conditions? When the umbilical artery shows absent or reversed end diastolic velocities, when the Doppler and ductus venosus Dopplers become abnormal, when umbilical vein pulsation appears, even when umbilical venous Doppler is normal, delivery is recommended. It means that if on ultrasound before 35 weeks, in preterm fetuses, if there is absent or reverse end diastolic flow velocity, or and there is abnormal ductus venosus Doppler, then these babies should be delivered in appropriate place where the provision of good neonatal care is available, and the mothers should be given before delivery a dose of steroids. The recommendation for the babies are more than 35. If the middle cerebral Doppler is abnormal, delivery should be recommended no later than 37 weeks of pregnancy. I mean, if we find that there is a abnormal flow in the umbilical artery and also in the middle cerebral artery, then fetus should be delivered by 37 weeks. In small for gestation, fetus is detected after 32 weeks of pregnancy with an abnormal umbilical artery Doppler no later than 37 weeks of gestation is recommended. It means if we find that the baby is affected, there is a defective, there's abnormal umbilical artery, abnormal middle cerebral artery, by 37 weeks, baby should be delivered. And if we see that the baby after 32 weeks, if we say that the baby is not growing well, there is abnormal umbilical artery, we should follow the babies, and then we should not prolong pregnancy beyond 37 weeks of gestation. So delivery is recommended. So in summary, intrauterine growth restriction is a major cause of perinatal mortality and morbidity. Diagnosis is a challenge for obstetrician, as most of the time we are confused in the diagnosis whether the baby is growth restricted or normally or small for gestational age or appropriate for gestational age. In that context, the dating scan is very important. So each and every pregnant lady should have dating scan, especially in the first trimester. And if we suspect fetal growth restriction by taking history of the mother, we should follow these women regularly by doing regular growth measurements, and Doppler vessel surveillance is fundamental. Timely delivery remains at the forefront of management. As the aim is to have healthy alive fetus, alive baby, then our aim should be to deliver the baby timely in appropriate place, and we should weigh the risk of prematurity and in keeping the baby in the intrauterine in the neural environment. So we have to be very vigilant in managing these patients, because if we take care of history, do timely investigation, and plan delivery accordingly, then we can get good result in terms of healthy baby and healthy mother. Thank you very much for a patient listening. If you have got any question, I will try to answer those questions.
Thank you so much, ma'am, for such an insightful session. Yes, we do have questions from our audience. And before I ask those questions to you, uh, all those audience who are listening to us, they can type their question in the chat box, and we will answer the questions accordingly. The first question is from Dr. Amara Salman, and she is saying that how we do differentiate between babies with symmetrical IUGR and normal small for gestational age babies.
Actually, symmetrical IUGR usually occur in the first half of pregnancy. There are problems with that. In those babies, all the other parameters are normal, like Doppler studies are usually normal. But in these babies, we usually find some problem like congenital abnormalities, like chromosomal abnormalities. So we should be very vigilant, because in the first half, if we find symmetrical IUGR, it could be a small for gestational age, appropriate for later on. So we have to follow. If we don't find any major problem, then we can follow these babies. The growth losses will be decreased, but they will be growing well. There will be no static growth. There will be no decrease in the severely IUGR. The blood flow velocity will be normal. The Leica will be normal, and in everything will be normal. So it's the follow up the baby. I mean, if we find in the first trimester there's problem like congenital abnormality, like we can label that or in the history the mother is having some history of infection, then we can label it. But otherwise it's really sometimes becomes difficult to differentiate symmetrical IUGR and small, because I use appropriate the constitutional small baby are also symmetrically growing, but they are growing at slow velocities.
Thank you, ma'am. We have another question from the same doctor. What is the frequency of scan in serial monitoring?
What does it mean? It depends upon we have to individualize the patient. We have to consider all the factors while doing advising. Recommendation is that if we find any risk factor, the frequency in these patients every 3 weeks, after every 3 weeks, we should do growth scans, because every week scanning will not give you the result. It can result into false positive results. So at least every 3 weeks interval, we should do fetal biometry plus umbilical artery Doppler. And if we find some problem, then we can modify our other line of investigation, like incorporation of CTG and other things in the management of the fetus. But the frequency should be every 3 weeks.
Okay, thank you so much, ma'am. Okay. Okay, ma'am. Thank you so much. We have another question from Dr. Rusa, and it is, what is the ideal mode of delivery of an IUGR fetus?
Actually, the mode of delivery is decided by I will say again, it is individualized. We have to consider all the factors in our mind. Senior obstetrician should be involved, neonatologist should be involved. Is the combined decision, and also the findings of the Doppler studies. Mode of delivery in patients who are having, in the fetus who are having reverse diastolic or absent diastolic flow, in those the mode should be cesarean section, elective cesarean section after giving single dose of steroids. But if the Doppler studies are impaired in terms that there is the and diastolic flow is present, but there is percentage index is reduced. This these babies can we take the chance of delivering these babies by induction of labor, provided we have got facility of continuous fetal monitoring, we have got the facility of the good nursery neonatal care, and we have got the facility of immediate cesarean section, where most of these these women and end up with the cesarean section. If the umbilical arteries are badly affected, then we should not take the chance of delivering these baby by normal delivery.
Thank you so much for answering this question. Uh, Dr. Zohra Hussain has a comment that, thank you, madam, for a very informative lecture, and no doubt it was a very insightful session. And that's all from the question answer sessions. And thank you so much, ma'am, for sparing your time. And thank you so much for all the participants who joined us in this academic session. The session is going to end. Ma'am, thank you so much.
Thank you very much for High Noon for arranging this very informative and academic activity for the audience. Thank you very much, Hassan.
It
And
was
the
all our
team of the
pleasure.
High Noon who are assisting me in this presentation. Thank you very much.
Our pleasure. Our pleasure. Allah Hafiz, ma'am. Allah Hafiz.
Allah. Thank you so much.